I welcome you to the first Lunch, Learn, Link seminar of the new academic year. As many of you know, this is a seminar sponsored by the Maryland Cigarette Restitution Fund grant, which is at the Sidney Kimmel Comprehensive Cancer Center. So you'll be receiving information about additional seminars as they come up over the year. We try to have 1 to 2 every month, and all cancer related. So if you all have suggestions for speakers, I'd love to hear them as we go forward. Ordinarily, we would be in Sheldon Hall as well as online here. And so this is Nicole Hughes and I's first time doing a webinar. So bear with us. But to kick off the season, we have Dr. Otis Brawley with us. He's been recruited rather recently, though it's been a year and a half, to Johns Hopkins. He's Bloomberg Distinguished Professor of Epidemiology and Oncology, and has come with a lot of expertise and publications in the world of cancer. So Otis, I'm going to promote your book, which is in, I don't know, the second or third or fourth or fifth printing, How We Do Harm. So, you can count on Otis for a new view of issues. So I'm looking forward to the talk today about cancer control in the 21st century. I know some of Otis's interests, but I haven't previewed the talk. So Otis, it's all yours.
Thank you. I'm going to
yes, you can put your slides up.
Share my screen here. I think I just did that right. Can you see my screen now?
Yes, that's perfect.
Great. It's wonderful to be talking to this group. Actually, it's a large group, and it's a little intimidating even for me because I see in the audience is Dr. Arlene Forestier and John Groupman, who are people who I've known. I almost knew both of them before I knew what Hopkins was, I should say. So let's just leave it at that. But it's wonderful to talk to you. And over the next 40 minutes or so, I'm going to talk a little about cancer control and new approaches to it and how we should be thinking about it. First, my disclosures. I do some work for the government and for Genentech. I did publish a book a few years ago, although the talk is not about the book, and I got 2 more coming next year. I want to discuss trends in cancer death rate over the past 3 decades, define race and talk a little bit about population categorization, define disparities as we know them in the 21st century, because it's really changing from previous years, and discuss approaches to overcoming those disparities. First, I want to note death last year in the United States. This is 2019 data. The estimated number of deaths from heart disease, cancer, so forth. Please note that coronavirus, something that we didn't even know existed in January of this year, is going to be the 3rd leading cause of death in the United States this year. Now, cardiovascular death rates have been going down as have cancer death rates over the past few decades. Cardiovascular death rates are going down faster. Cancer will become the most common cause of death within the next 5 to 10 years, surpassing heart disease. This is just showing age-adjusted cancer death rates in the United States over the last century. You can see 64 per 100,000 in 1900, 215 in 1991, and that was the peak. And there's been a 29% decline. Again, this is age-adjusted to the year 2000 standard. Now, that 29% decline, when we look at the OMB-defined racial and ethnic groups, falls like this. You can see blacks in light blue, and they have had the largest decline, but they started out higher than anyone else. This graph actually shows that there is a disparity between whites and Native Americans, whites and Hispanics, and whites and Asian Pacific Islanders. The Native American number is basically flat, and there's a lot of noise there because they represent between 1 and 1.5% of the entire population. But you can see since 1990, these are the declines that we've had in age-adjusted mortality rates for the races and ethnicities as defined by OMB. When we look at breast cancer, prostate cancer, and colorectal cancer for men and for women, these are the patterns for breast and colorectal cancer. I want you to notice that in the 1970s, there was relatively little black-white disparity in death rate. And the disparity really came about in 1980 or so. When we started learning how to screen and treat for the disease is when we began having black-white disparities. And the disparity is greatest for breast cancer now than it's ever been. For colorectal cancer, it's starting to decline. And I have no idea what's going on with prostate cancer, but this is prostate cancer for black men and for white men, and then for the other 3 racial ethnic groups. Now, I noted earlier that race is defined by the Office of Management and Budget in the White House. They define race about 2 years before every census. And this is really important that racial definitions change. In the United States Census and the United States government collection of data, there are 2 ethnicities, Hispanic and non-Hispanic. It's very non-scientific in many respects. And indeed, the Office of Management and Budget admits that their definitions are sociopolitical and not biologic. The anthropologic community rejects the use of race in the collection of data. And I already noted race changes over time. The best example of race change—
I don't know your experience, but mine has been that it just doesn't have to be super detailed. That's at least, and Christina, you can speak to that as well, right? So a lot of ours, our moderator guide, both for here in Baltimore and our global ones, have really been theme-based, right?
Hello? Hello? I'm sorry. Race changes over time. The best example of race changing over time has actually been the fact that Barack Obama, by these definitions, was considered white in 1970 and black in 1980. The 1970 census actually said you should declare yourself to be the race that your mother considers herself to be. The 1980 census said declare yourself to be the race that you consider yourself to be. Now, there's been a lot of discussion about diversity in clinical trials. A lot of this is really political and not scientific, and it stems from the NIH Revitalization Act of 1993, which called for valid subset analysis amongst the races and ethnicities. And many have actually thought that this actually codifies in federal law that race defines biology, something that OMB and the anthropologists reject. The other issue with the valid subset analysis issue in clinical trials are that subset analysis are not statistically significant by nature. That being said, clinical trials participation amongst all people should be encouraged, especially since there's evidence that participating in clinical trials is a way of getting better quality of care and getting care from doctors who participate in clinical trials, even if you don't go on to a clinical trial, gives you better quality of care or a better chance at quality of care. So to sum up, race is not a biological categorization. It's a socio-political construct. An area of geographic origin can be a biologic categorization, but Ancestry.com has shown us that that can be really, really difficult. And as Harold Varmus is fond of saying, to divide the country up into 5 racial and ethnic groups is like trying to slice soup. The clinical variation amongst populations. I just wanted to give you a couple examples of this. This is not race, but these are defined populations. There are forms of G6PD deficiency common amongst people originating in certain areas of the world. There's one particular HLB 1502 allele, which is common among people who live within 100 miles of either side of the Thai-Burmese border. And those people, 20% of the people who live within 100 miles of the Thai-Burmese border have this allele. And if you give them the anti-seizure drug carbamazepine, they get a Stevens-Johnson reaction with raw mucous membranes and peeling of the hands and feet, skin of the hands and feet. This is 20% of people who live within 100 miles of the Thai-Burmese border. It's not all Thai people, it's not all Burmese people, it certainly is not all Asian people. Again, there are certain groups of people who have certain distinct genetics, but to use race is inappropriate. And then the other very good example is the sickle cell mutation has a prevalence amongst people originating in southern Greece, Italy, and into the Middle East, a higher prevalence amongst people in sub-Saharan Africa, but people native to South Africa don't have sickle cell disease. Now, if you find someone in South Africa who does have sickle cell disease, and there's a lot, you will find that they or their relatives within the last several generations are migrants from up north, from sub-Saharan Africa. And so I've now defined white people who do get sickle cell disease and black people who don't. Again, race is not a great way to categorize populations by genetics. Now, the development and use of tailored drugs, which is very popular right now, is using 30 to 50 person phase 2 studies as a surrogate for improvement in survival. From a scientific standpoint, we're going to have a lot less emphasis on racial differences and a lot more emphasis on genomic targets. And I think progress in science is pushing us to be more scientific and less dependent upon race, which is something we should appreciate for socio-demographic reasons. Now, let's talk about that 29% decline in cancer death rates. I would attribute it to wise early detection, and there is unwise screening and early detection out there, and improvements in treatment, as well as prevention, especially tobacco control. When I talk about screening, it can be beneficial, it can also be harmful, it's often both. And we really need to support good randomized studies to figure out what the risk-benefit ratio of every screening intervention is before we implement it in a large population. Unfortunately, with PSA screening, with mammography and other things, they were implemented before they were fully adequately assessed. These are from Graham Kolditz's list of the causes of cancer. I'm a big advocate for prevention. I believe that we as a country have not really appreciated and not really practiced cancer prevention as much as we should. This 33% is a figure which is moving, I think, because we found out over the last few years more and more cancers are caused by smoking. Indeed, when it was first published as 33% in 1980 by Pito and Dahl, it probably should have been closer to 40, 45%. But back then, we only knew 12 cancers were linked to smoking. Now it's at least 18. Energy balance, the combination of overweight, a bad diet, which is usually too many calories, and lack of exercise, makes up 30% of all cancers. It is the second leading cause of cancer nowadays, and indeed will become the first leading cause of cancer over the next 10 years with decline in smoking. I also want you to, this is an American chart. If we were to look at Asia or Africa, viruses and infectious disease would be higher. Alcohol is not appreciated in this country, that it causes cancer. UV and ionizing radiation includes radiation from medical procedures to include screening and diagnostics. We need to think about all of these things. This is smoking in the United States. The younger folks watching this talk may not be aware that in 1955, 55% of American adult men smoke cigarettes, and here you can see the decline. The height for women was 1965 at about 35%, and here you can see the decline. Tobacco is still the leading cause of cancer, but it will be surpassed by diet and energy balance because of that decline. And keep in mind, there's a 30 to 40-year lead time. The people who did not smoke or stopped smoking in 1970 are now not developing cancer and not dying from it in 2020. This is smoking rates in the United States for men and women, and you can see the age distribution. Smoking prevalence by race: non-Hispanic white women, non-Hispanic white men, blacks, Native Americans. Native American figure is a little bit misleading. If one goes to southwest US, to New Mexico, Arizona, where actually Hopkins School of Public Health does a lot of work on Indian reservations, there's almost no smoking there. And then if you go to the Plains Indians in North and South Dakota, you find very, very high rates of smoking. And then Asian Pacific Islanders and Hispanics. And Hispanics, of course, are a very heterogeneous group of people. By education, notice high school dropouts. This is true for GEDs. It's not a typo. There's something psychologic, I think, about people driven to get a GED, that they smoke a lot. And note the decline as we look higher and higher in education. This is tobacco use in 2013 by state. And you can see in the dark red are the states where we have the highest smoking rates, up to 27%. Utah and California had smoking rates that were closer to 10%. And so there's huge variance in smoking by state. Cancers caused by infection, especially the hepatitis B and C and HPV, are significant issues. And these are especially significant because we can prevent hepatitis B and human papillomavirus with vaccination. We can treat hepatitis C. There are some huge socioeconomic issues and state-by-state issues in that some state Medicaid programs will not pay for the treatment of hepatitis C. And the cure of hepatitis C can prevent cancer. Now, I've talked a great deal already about energy balance. 2/3 of adults and 1/3 of children are currently overweight, and weight-related cancers are going to account for 30 to 40% of cancers by 2030. This is a slide that shows obesity, not the status known as overweight, but obesity in some of my favorite countries. You can see in the United States, obesity rates were at less than 15% around 1970 and went to 35% by 2010. And you can see in England, Canada, Spain, France, Korea, much lower obesity, although a slight trend upward everywhere. In the United States, we have a special problem with obesity in non-Hispanic Black women, who are close to 60% now. There's been a rise in Black and white men and white women as well, but not nearly the problem we see in Black women. Now let's look at a couple of diseases and try to come up with some cancer control pearls. In breast cancer, these are the American Cancer Society estimates for 2019, and there's been a 40% decline in age-adjusted mortality from 1990 to 2016 in breast cancer. That's to say, your average age woman of, say, 55 or 60, her risk of dying from breast cancer today is 60% what it was for a woman of the same age in 1990. I would actually call that progress. And by the way, studies show that 40% to close to half of this decline is due to screening. The remainder of it is due to improvements in treatment. A small proportion of it is due to women simply being empowered to find something in the shower, not a formal breast self-exam, but find something in the shower and being empowered to go to the doctor and say, what is this? We call that early detection. You've seen this slide before, just different colors. The death rate for Black and white women in the 1970s were the same. The change that occurred around 1980 as we started learning how to screen and treat the disease, and the fact that the disparity in death rate is greater today than it has ever been, and the other three race ethnicity groups being below. You've seen this pattern before. Very important point. There are 7 states in the United States where there is no Black-white mortality disparity. This is the United States Black-white disparity as a whole, but there's 7 states where there's no Black-white disparity. And that leads one to wonder what's going on state by state. Now, I told you there was a 40% decline in death rate for women with breast cancer, in breast cancer death rate since 1940, since 1990. This is the decline by state since 1990. You can see the states in dark blue, 44 to 51%. The states in purple, 20 to 29%. The United States was relatively homogeneous for death rate until the 1980s, and now we've seen these declines. What's the difference between why 51% decline in Massachusetts, 20% decline in Mississippi? And indeed, as we move into the 21st century, instead of Black-white disparities and Black-white differences, we're starting to look at state-by-state differences, the differences between people in the Northeast and in the South. And this pattern you're going to see quite frequently. By the way, SysNet analysis, SysNet being a mathematical modeling program, has actually looked at women dying from breast cancer. And the estimate is that of the 50,000 or so who die from breast cancer every year, somewhere around 10% die because of inadequate screening, but somewhere between 21 and 27% die because of the lack of appropriate treatment after diagnosis. And this is very important because when I was chief medical officer of the American Cancer Society, people love to preach screen, screen, screen. Go get a mammogram. I don't hear too many people say, go get adequate treatment once diagnosed. And adequate treatment once diagnosed is a bigger driver of breast cancer death, or lack of adequate treatment is a bigger driver of breast cancer death in the United States than screening or lack of screening. Now let's look at colon cancer. Colorectal cancer, these are the numbers diagnosed and the numbers dying in 2019. There's literally been a halving of the colorectal death rate in the United States since 1980. The average man or woman in the United States, their risk of dying from colorectal cancer today is half what it was for someone of the same age in 1980. That's real progress. Screening is probably 2/3 of that decline. And this again, you've seen this before, this is death rate for women, Black women and white women, the other groups, racial ethnic groups, death rate for Black men, white men, and the other racial groups. Something happened around 1980. We learned how to screen, diagnose. Treatment also improved at that time. Now, this is actually a slide that was developed by us at the ACS to support the Affordable Care Act. Now, I generally hate survival statistics because I've seen so many people, even doctors, misuse 5-year survival statistics. This is one 5-year survival graph I'm going to show you. Red is stage 1 colorectal cancer, blue is stage 2. The dotted lines are uninsured or people who got Medicaid immediately after diagnosis. The solid line are people who had private insurance, including private insurance for prevention, meaning they could get screened, or if they had a problem, they could go to the doctor and their insurance would help them pay for it. And at 5 years, 60 months, the death rate or the sort of the 5-year survival for people who had stage 2 disease with insurance is greater than the 5-year survival of stage 1 disease without insurance. This graph was built, or this graph was constructed to show that insurance matters. Note, even within stage 1, the stage 1 uninsured at diagnosis don't do as well as the stage 1 insured. Stage 2 insured do better than stage 2 uninsured. By the way, even stage 4 insured do better than stage 4 uninsured. But in the United States of America, in the 2009-2010 era, you were better off having stage 2 colon cancer with insurance than stage 1 colon cancer without it. Now, I mentioned the 50% decline in death rate across the United States. This shows you the 55 to 63% decline in colorectal cancer death rate since 1980 or so in the Northeast, and the 12 to 31% decline in the South. Again, disparities is becoming much less black-white and much more, in this case, Massachusetts versus Louisiana, 63 versus 12. Very similar prior to 1980 death rates, but huge divergence since 1980 or so. And this is just a graphic. I won't dwell on it, not graphic, but a slide. I won't dwell on it too much. Kim Rhodes at UC San Francisco has actually noticed that there are huge racial differences in terms of the number of lymph nodes looked at in people who get surgery for colorectal cancer by race. Blacks average somewhere around 6 lymph nodes assessed, whites somewhere around 18 lymph nodes assessed. And part of what, this is actually when I started talking about institutional racism in what we do. There's a lot of data about colon cancer being more aggressive in blacks versus whites. Some of that data is based on the fact that stage 2 blacks are almost as likely to relapse as stage 3 whites. Well, it turns out most of those stage 2 blacks are stage 2 because a pathologist looked at 6 lymph nodes and 0 had cancer in them, so they were categorized as stage 2. Many of the whites who are stage 3 are stage 3 because a pathologist looked at 18 or more lymph nodes, and 1 of those 18 lymph nodes had cancer, so they're called stage 3. The whites are better staged than the blacks. She later found out that the inadequate staging tended to go with the hospitals that the blacks are treated in, and the pathologists where the blacks were treated, they had 6 cases a day to deal with on average, whereas the pathologists where the whites were treated had 2 cases per day. It's just an example of how structural racism can lead us in medicine to think that there's something biological about being black when it's actually socioeconomic and access to adequate staging. So for colorectal cancer disparities, we need to focus on improving these differences. There are differences in the prevalence of screening, the quality of screening, the proportion treated, and quality of treatment, even differences in the pathology. And these differences are by race, socioeconomic status, and to region of residence now. Let's look at lung cancer. This is the estimate for lung cancer in 2019, about 154,000 deaths last year. This is the lung cancer distribution. I showed you the smoking distribution earlier for 2013. It's not a surprise we have more lung cancer deaths in the South and in the areas where there's more smoking and where there's been more smoking. But I want to point out the death rate from all cancers in Kentucky is 195 per 100,000. In Utah, it's 125 per 100,000. There is a Kentucky versus Utah disparity. We used to talk about race. Now we're starting to talk about states. Huge push toward lung cancer screening by some groups over the last several years. This is the New England Journal of Medicine paper done by the National Cancer Institute, and a number of people. Hopkins participated in the NLST. 54,000 people at high risk for lung cancer because of age and smoking status, randomized to screening versus a sham chest x-ray. This was done every year for 3 years, and then they were followed over the next decade. 20% reduction in relative risk of death. Lots of publication about that. But I, as a screening person who tends to look at both sides of the issue, would like to point out that for every 5.4 lives saved in this study, 2 people ended up going to an intensive care unit after a complication from an invasive procedure, and 1 person died within 60 days of an invasive procedure. This, when it's done in 30 of the best hospitals in the United States and people who volunteered to go into a study. And I worried, what's it going to be like when this is disseminated and implemented across the United States? Well, if every hospital in the United States are as good as the 30 hospitals that did this trial, and every person eligible for lung cancer screening is as good as the people who volunteered to go into this trial, of the 160,000 or so who die every year of lung cancer, we would estimate that if we screened everybody and gave everybody the care that was given at these 30 hospitals, we would prevent 8,000 to 10,000 deaths per year, but we would cause 1,500 to 1,850 deaths per year. The benefit and the risk of screening. Number of respected groups, by the way, have published statements saying that if people qualify for the NLST, those who understand that there are risks and there are also benefits should consider getting the screening. Unfortunately, a number of organizations publish calls for informed decision-making. That frequently does not get translated to the common man. It certainly did not in prostate cancer screening, where there's still calls for informed decision-making, and it's not being translated in lung cancer screening. I point this out because there are a number of Black and socioeconomically deprived people in this country who are suspicious of us in medicine. And when we are not truthful to our own recommendations, we don't appreciate that we should inform these people of the benefits and risks, and then let them make their own decision and appreciate that they're making their own decision, respect that decision. We actually are setting ourselves up, and I think rightfully so, deserve some of the suspicion that we get from those communities and the lack of collaboration. Now, enough of my preaching. The most important question in cancer control really is, how can we provide adequate, high quality care to include preventive services to populations that so often don't receive it? I want to point out, unnecessary care interferes with an institution's ability to provide necessary care. This is especially a problem in poor institutions, poor hospitals. If they get distracted providing lung cancer screening, for example, they have difficulty providing other more necessary care that's more likely to save lives, as well as state-by-state disparities are increasing with the Affordable Care Act. What I mean by that is, in blue are the states that have expanded Medicaid such that adults age 18 to 65 who don't have insurance can qualify for Medicaid and use that Medicaid for preventative services as well as for diagnostic and treatment services if they're sick. The orange states are states that have not expanded Medicaid. And we are, I believe, if we continue with the Affordable Care Act, going to have greater and greater disparities between some of the states in the north and some of the states in the south because of the availability of care. Now, summing up, as I was leaving the American Cancer Society, I challenged the epidemiologists there to try to describe and quantify disparities for cancer in the United States. And Ahmadine Jamal and I got together and realized that college education does a lot for the prevention of cancer. We showed you the smoking rates earlier. But something about a college education in any race, it decreases risk of death from cancer dramatically. And the American Cancer Society every year publishes an estimate of how many people are going to be diagnosed with cancer in a given year. We simply decided to say, gee, we know 600,000 are going to die from cancer in a given year. How many would die if everybody had the risk of death of college-educated Americans? And the answer is 132,000 deaths would be avoided if every American had the risk of death of college-educated Americans. Think about that. 22% decrease in the number of deaths, 132,000. That's the number of people who would not die if every human being in the United States got what college-educated people got. That's the prevention, the screening and diagnosis, and treatment. Stress, they get the prevention as well. That 132,000 deaths averted is greater than any breakthrough screening tests, greater than any breakthrough treatment that we've ever had. The number of people whose lives could be saved if we got every human being what every human being ought to get. We also were looking at who those people are, and it turns out 80,000 of the 132,000 are white Americans. The largest group of people in the United States to suffer from health disparities in cancer, at least, and probably true in diabetes and heart disease, are white. They live in virtually every state, by the way, but they disproportionately live in those orange states on my Affordable Care Act map. And so the issue of health disparities is not just a racial one anymore. And we really need to focus on disease prevention, smoking, diet, exercise, alcohol, and vaccination, as well as getting optimal care to all people, appropriate screening, appropriate treatment. How can we provide adequate care is, I think, the most important question that any of us can ask at this time. And I want to stress again, unnecessary care interferes with abilities to provide necessary care. Last slide. Population disparities always increase when there's scientific progress. We saw that in colorectal cancer. We saw that in breast cancer. It's going to be seen as we move into the era of precision medicine and immunotherapy. And one thing that has always struck me, new preventive interventions have always been less likely to cause significant disparate outcomes in the long term. I'm very impressed by the fact that there are no disparities in this world right now in smallpox. In most Western countries, there are no disparities in polio. There are no disparities by socioeconomics, at least, in measles or mumps or rubella. And so I said last slide earlier, I just want to point out certain groups, sometimes it'll be Appalachian whites, need a little bit more to get where we all want to be. We don't need equality, we need equity. Certain groups will need a little extra to get where we all want to be. And I thank you. 40 minutes.
Thank you so much, Otis. I really appreciate your bringing really a great span of issues to us. For the listeners, please submit your questions for Dr. Brawley via the chat. I will be monitoring that. We do have a first question in the chat, and it's has to do with institutional racism, perhaps. It's phrased as, is institutional socioeconomic segregation a valid term? And if so, how can it be resolved?
Say again?
Is institutional socioeconomic segregation a valid term? And if so, how can it be resolved?
I'm not sure. That's a question a little bit above my pay grade. I think one of my great problems is a lot of my Black colleagues have come to believe that there's some of these biological differences that I actually find are oftentimes geared toward socioeconomics. And some of us have just come to expect that some of these disparities just have to exist and there's nothing that we can do about them. And what I'm trying to do is focus more and more on prevention. Now, I'm worried tremendously. You and I have had great conversations about my concern that obesity in childhood increases risk of breast cancer later in adulthood, and that sort of thing. Rather than worry about the labels, let's worry about the problems and the solutions.
So, Dr. Brawley, a question for you from myself about how should we set our goals? So, as you know, the Cancer Center works closely with the state of Maryland for looking at 5 years at a time and moving the needle for our state's progress. As you pointed out, states differ on that. How do you think states like Maryland should set their targets? Should they just aim to lower all of them, or is reducing disparities a good way to go about it, or something else?
Well, I would really, really like politicians to be concerned about healthcare and outcomes, number one. Number two, I would like politicians to be concerned about science and truth. I really sense that there are a number of politicians, and this is not a Republican or Democratic statement. I sense there are a number of politicians who don't understand the science, and there are a number of people in the United States, politicians and otherwise, who don't care about their fellow man. That being said, I'd love to see efforts to try to get every human being the care that every human being deserves. If you want to focus on a particular problem in a particular population, I think that's fine. The work that you do to try to define, that we have a colorectal cancer problem in this area of Maryland, and it's primarily in this group of people, I think that's great. And then you try to develop interventions to fix that. But the global problem is people just don't get the care that they need. The global problem is we have totally ignored teaching young kids about exercise and diet and pushing good diet in childhood.
Alrighty, Otis,
Hey,
we
Norma,
have another question
Hey,
here.
Norma, before you go on, it's Elizabeth. I want to interrupt because I liked your question, and I actually want to get a finer point on what you raised, Dr. Brawley. So Norma is making a point that if we tackle the problem of cancer overall, everyone's rate will reduce, but you could still have a disparity. So even though everyone may have a lower risk of cancer, the disparity can still remain. So she was asking about setting goals for, say, in state cancer planning. So should we separately set goals? Like how do we best approach this, right? Because we want to benefit everybody. Yeah. And we want to make sure that people who have not benefited to the same extent actually do benefit.
Well, two answers to that. And by the way, both you guys know I'm fine with being called Otis in public. You normally call me Otis. Please call me Otis. Um, I really do think that if you focus on one particular group, there's going to be some bleeding of benefit out into other groups. Number one, and other diseases, for example. You know, in the 7 states, they've gotten rid of the black-white disparity in mortality. I'll bet you that the black-white disparity in colorectal cancer has been lessened because of it. I'll bet you the Asian and Native American and poor people in those states are better off because of that. We just haven't measured it perhaps as well. And again, other diseases have improved as well. Especially, all the chronic diseases are caused by all the same things.
Thank you. So what you're saying is, you know, some of the memes that we've seen recently with, you know, showing people having boxes of different heights, or let me do a better one with, if you clear the ramp from for snow first rather than the stairs when there's snow, you benefit everybody because everybody can go up the ramp.
That's right.
Right. So it's the same concept. That's your point. Yeah.
Mm-hmm.
That's great. Thanks.
All righty, great. You know, I'll just insert here, since we're carrying on with the question, that years ago, there was a proposal made to measure variation among subgroups in the population, and one goal being to reduce that variation. And Otis, your talk makes me think maybe we should be looking at that as to whether or not states are getting closer together in terms of their cancer burden and the outcomes we measure, or is it just that overall the best states are contributing, you know, to the decline? So we should try to pursue that.
Yeah, I think there's been some improvement in every state. It's just that it's much more homogeneous when you go to the states in the Northeast. I should point out, the Affordable Care Act did not cause those declines in breast cancer or colorectal cancer. Indeed, the Affordable Care Act's effect on cancer mortality is probably starting to show up in data right now. The states in the Northeast were doing something that, for some reason, those populations were much more in a health promotion mindset in the 1980s and 1990s than the states in the South that have had, you know, really marginal success in lowering mortality rates.
Okay, so we have a couple questions here in line. So let's read this one. My question is, what role can pharma play in decreasing health disparities?
That can be a loaded question. I'll be very honest. I worry about price of drugs. I worry that some of the drug programs to get drugs, expensive drugs, to people who can't afford them actually increase some of the disparities. These are things I worry about. I don't have all the answers for. I worry that some of the advertising for some of the high-end drugs actually increases unnecessary demand for those drugs and actually create more health costs and more disparities because of them. I've been very hard on the drug companies so far. I will say that some of the drug companies' efforts in the community, I think, have been very good and very important. The drug companies have supported some of the advocacy organizations that have put cigarette taxes out there that have lowered the smoking rate and have done, I think, some positive things there as well. But I think every drug company needs to sit down and think how we can be most constructive in helping to reduce the disparities and improve health in the United States. I think that's an important question. Some have done it, and I don't want to be overly harsh on the drug companies, and I respect the idea that you have to make a profit.
All righty, thanks to Corinne Toomer for that question. Arlene Forestier asks the next question: is the effect of college education really due to access to subsequent employer-based private health insurance? Again, getting back to the failures of our healthcare system.
It is partially the availability of access, but it's also the ability to utilize that access. One of the reasons why I'm so into navigation programs is there's a goodly number of poor people, not just Black people, but poor people who now have access to care because of the Affordable Care Act, but they are not medically sophisticated enough to utilize that access to care, or even, for example, to find their way through the big intimidating hospital to the particular clinic that they need to go to, and to deal with the obstinate clerk behind the desk. So a lot of that is a problem, as well as college-educated people tend to exercise more, they tend to not smoke as much, they do a lot of things that are preventive of disease as well. So it's a consumption issue and a prevention issue, as well as that affordability and access piece.
Thank you. So multifactorial.
Yes, ma'am. Thank you for coming to this.
Any other last questions here? We have a couple more minutes. Manoush? No. Well, thank you all for attending. Let your colleagues know that this session was recorded and will be available at our Cancer Prevention and Control website. We will send out a notice when it is available, and stay tuned for additional seminars to come up. Thanks again.